Good afternoon, everyone. I'm Korean, a nephrologist from Korea. I'd like to express my sincere thanks to the organizers and chairs and Professor Vivek Kute for giving me this wonderful opportunity. I have no conflict of interest to declare. Today, my presentation is simple, 5 parts, 1 story, best practices in transplantation from Asia with a focus on kidney transplantation. There are 47 countries in Asia according to WHO and World Bank classifications. So naturally, there are many best practices across the vast and diverse region. The world recorded over 1.7 million transplants in 2023. Nearly 2/3 of them were kidneys. Kidneys dominate in Asia too, 77% in East Mediterranean region, 75% in Southeast Asian region, and 63% in West Pacific region. Altogether, Asia accounts for 36% of all KT worldwide. We used the GODT data from 2019 to 2023, excluding the COVID years. During this period, KD activity rates in Asia increased overall. However, even within the same region, the variation in transplant activity is striking. Out of 47 Asian countries, only 27 reported it to GODT, that's just 57%. In EMR, only 2 countries exceeded 30 PMP, and WPR only 3. So yes, progress is happening, but it remains uneven and fragile. In contrast, the 2023 ISN Global Health Atlas shows that most Asian countries highlighted here in purple carries a very high burden of kidney failure. Unequal transplant activities within Asian countries has a darker side. Asia become a hotspot for organ trafficking. H is a kidney transplant database with a real-time visualization and automated validation covering 227 variables. Right now, 9 transplant specialists from 7 countries are participating. 77% of H patients are from South Asia, providing key insight into KT there. The median recipient age was 41, much younger than 51 in Korea's Kotri database. The most common cause of KT was glomerulonephritis, which accounted for 53% of underlying diseases. The proportion of patients with diabetes and cardiovascular comorbidities were very low at 17 and 1.5% respectively. So, KT activities in Asia remains far lower than in Europe and the Americas, with wide variation across countries. And Asia still depends mainly on LDKT. So, preventing CKD and strengthening LDKT are first step forward. This slide summarizes government-led CKD management policies across Asia in the past 5 years. Among those, Taiwan's policy is particularly noteworthy. Taiwan implemented a universal CKD care program known as Pay for Performance, P4P model. This program manages CKD stage 1 to 5 through team care and education with performance-based incentives. As shown in the study by Lin, P4P has significantly reduced the long-term trends in dialysis incidence. This program shows the value of dedicated government resources to CKD management. As the 2024 WHO Santander meeting highlighted, transplantation not only greatly improves survival, but it also far more cost-effective than dialysis, making it an ideal solution for LMICs. As you may know, LDKT is still far outnumbered DDKT in both EMR and the Southeast Asian regions. The use of paired kidney exchange, ABO-incompatible transplantation, and the broader acceptance of marginal donors, all of which have significantly expanded access of LDKT. As you all here already know, India Kidney Paired Exchange Program allows incompatible donor-recipient pairs to exchange donors for compatible match. And I will skip this part because you have heard about it already. Therefore, I would like to highlight Taiwan's CKD management program and India's paired kidney exchange initiative as best practices in KT in Asia. The next step is to increase KT, is expanding deceased organ donation and transplantation DDOT program. The rate of DDOT remains very low across Asia, with large differences between countries. Among the 24 Asian countries that submitted data to GODT, 83% performed both living and kidney donor KT, while 17% conducted only LDKT. And only a few Asian countries exceeded the global mean of 15 PMP in DDKT activity. In abstract data, about 21% of KT were performed deceased donors, most of them brain dead from traumatic injury. Laboratory infrastructure remains fragile. 47% of cases were done without CDC T-cell crossmatch. In 2024, at the TTS Congress in Istanbul, we hosted a seminar and workshop with LMIC participants worldwide to discuss barriers to DDOT. This slide summarized the common themes identified in LMICs: weak brain death legislation, limited government funding, cultural and religious misconceptions, etc. At the root of many these barriers lies a fragile economic foundation, as emphasized in 2021 transplantation paper by Professor Mudai. Not surprisingly, countries with higher Human Development Index achieve higher organ transplantation rates. Implementing DDOT always incurs cost for managing deceased donors. Without sufficient policy or funding support, program stagnate and transplantation tourism increases. When we compare the total KT rates with HDI, we found a positive correlation about 0.6 in Asia. Yet, 53% of Asian countries fall below the global trend line, showing that non-financial factors also play a major role. The gap is even wider for DDKT. 73% of Asian countries fall below the line. Still, several countries, such as Iran, Thailand, China, and Mongolia, stands out with relatively higher DDKT activities for their HDI, representing overcoming financial barriers in DDKT. Among countries that have successfully overcome financial barriers, Iran and Mongolia stands out as remarkable examples. Iran's model combines strong regulation with mixed financing, public funding, drug subsidies, NGO participation, and direct government support. Through national oversight, this system removes major cost barriers and endured long-term sustainability. government-regulated social funds over surgery, insurance, and funeral expenses, along with the benefit for low-income families, while strict regulation prevents blockage. Lifelong immunosuppressive drug subsidies are guaranteed. By sharing the cost burden across the society, Iran achieved notable success in DDOT, as shown here. This model also helped address ethical issues in the formal living unrelated donor program and significantly reduced dialysis-related costs. To build a stable and lasting DDOT program, government must establish a dedicated national body and allocate budgets according to their capacity. A leading example in Asia is Mongolia. In 2011, the country performed only 10 to 15 kidneys transplant per year. Then physicians trained abroad took the lead and persuaded the government and the public to make transplantation the national priority. They helped establish the national body within the Ministry of Health to oversee regulation, coordination, and financing. Today, Mongolia operates an internationally recognized DDOT program that has expanded beyond the kidney to include liver and other organ transplants. In this section, I introduced the two Asian best practice, Iran and Mongolia. Next, I will explore how organ transplantation in Asia is shaped by diverse cultural and customary practices. At the TTS 2024 workshop, 5 main cultural barriers to DDOT in Asia were identified. Cultural and religious belief ranked as the most influential factor, followed by public distrust in healthcare system. Comparing 2023 with 2019, GeoDD data showed that DDKT is increasing in several Asian countries, including Malaysia, Qatar, UAE, India, and Thailand. In 2023, Thailand and China stood out. Over half of all KT there came from deceased donors, so this section we will focus on these two countries. Although all major religions support deceased organ donation, distorted interpretation often leads to its rejection. Asia, home of most of the world's major religions, faces these challenges. Thailand, a predominantly Buddhist country, once struggled with belief about disturbing the spirit, rebirth, and body integrity. Thailand overcame these barriers by reframing organ donation as an act of making merit a deeply spiritual contribution. At the center of this change was the Thai Red Cross Organ Donation Center, which established unified registry, transparent allocation, and strong family support. Through faith-based trust and national coordination, organ donation became culturally acceptable practices. Temples become a registration site, and the monks actively promote the message that saving lives brings merits and influence rebirth. As a result, Thailand achieved a broad public acceptance and participation. The second major cultural barrier is public distrust in the health system. Distrust arises from past unethical practices, weak legal safeguards, lack of transparency, and unequal access to transplantation. China fundamentally reformed its system after 2015, banning the use of organs from executed prisoners and building a national donation and allocation framework. The government established COTRS, the China Organ Transplant Response System, a nationwide digital platform operated by National Health Commission and the Red Cross. Its automated matching system guarantees fairness, transparency, and accountability, while continuous data integration supports quality control and national oversight. As a result, China performed 24,000 organ transplants in 2024. The key lesson is clear: public trust grows through visible ethical transform and unified national IT system that guarantees transparency and fairness. Asia has many remarkable clinical and science best practices in transplantation. I've selected these 6 national programs from non-high-income countries because each has successfully overcome key challenges they face through national unity and innovative policy. These experiences remind us that progress in transplantation is not only about technology, but about trust, leadership, and shared responsibility. I hope the wisdom of these programs will inspire and guide many Asian professionals and policymakers striving for self-sufficiency in organ donation and transplantation. Thank you very much for your attention.